to make it too lecture-y, but it's inevitable I'll get there. I do tend to ramble, and I apologize. So my name is William Albright. I'm a board certified, William Albright, board certified plastic surgeon, certified by American Board of Plastic Surgery. I am an original San Antonian, I guess, and just recently returned here after training in other states. And then my first job was in the University of Iowa. I was there for 3 years and moved back home to raise our kids. So it's been a fun transition for me to come back home after 17 years away. It's a little bit different and a little bit the same. And I always make the joke that when I left, they were starting the 281-1604 interchange, and still working on it, and that's okay. I started Alamo Plastic Surgery here, solo practice right now, but we intend to grow. And our mission is to provide exceptional value. That's the key. And how do we achieve it? Through patient education, empowerment, and surgical results. And before I kick off into the bulk of the lecture, it's a special place to me because, and this maybe frames it for everyone else, but I myself, my mother has had a room-wide gastric bypass about 3.5 years ago. And I have an older sister who had a sleeve gastrectomy, or partial gastrectomy, maybe 1.5 years ago. That's probably about right. And so, this is personal to me as well as professional. So, just to put things in perspective, I try not to come off as being disparaging or discouraging. I always tell my patients I want to encourage and not discourage you. But I also try to be realistic. Having realistic expectations help avoid confusion and unsatisfactory results. So, being realistic is helpful. And so, this lecture is framed in that vein. It does have some graphic stuff in it. I tried not to put too graphic of items, but I saw there were a couple of kids who walked in, so just be aware of that. Also, from looking at the crowd, we have a few fellows here, and so this is typically more geared to a female audience, but there's a little bit in here that's applicable specifically to men. So I apologize for that. Probably should have put more stuff in there for men, but here we go. So, fatty deposition, right? People talk about apples and pears, and apple tends to be round, carrying the bulk in their midsection. A pear is more of a feminine shape, kind of narrow in the upper body, torso widening down to the hips. But it can be mixed and matched in all different sorts of places. Face, neck, back, chest, abdomen, arms. You can have different combinations of all these things. Why is that important? Well, after weight comes off, you're going to have different problems that need to be addressed, and they're going to be different severities depending on what shape you were naturally gifted with. And so we'll talk about that. We can't really do a cookie cutter approach to body contouring after massive weight loss. It's not appropriate. It wouldn't work. We have to talk about visceral fat. So this is fat and bulk that is not underneath the skin. It's deep to the abdominal wall. It's around your internal organs. And it applies volume that we can't really address surgically, at least by the techniques that I would use and most plastic surgeons. And that's addressing specifically fat that's just underneath the skin and not inside the abdomen. And we'll talk about why that's important when you're picking body contouring procedures and knowing what a limitation might be. Does tend that men will hold more of their fat as visceral fat, but that's not always true for everyone. I see plenty of women who have intra-abdominal fat as their primary fat source. And it's distressing because it does limit what we can achieve as part of body contouring. and you'll see pictures of that later. So here are more, right? Body types, all different shapes. These are patients who've had, quote unquote massive weight loss or significant weight loss, and you can see their shapes vary. The severity of the changes in their anatomy are different depending on their the body part you're looking at. So breast, arm, in this kind of cone, abdominal cone or inverted cone. The thing that I take away from that is really that there's excess skin top down, right? So that's what you see when you're standing up, and you see the fold and then the fold and then maybe more folds. But if you were to put this figure or this patient on her side, right, the skin also hangs down that way. So we have excess skin that we need to address in a top-down, head to toe fashion, but also in a side-to-side fashion. So it's kind of two planes, like 2D that you have to work in. It's really 3D, but on this picture it's 2D. The same thing is true of many body parts, right? So this is also true very commonly in the mons, the excess skin of the pubic mound. Very common to have excess skin that's top down, but also side to side. You have to address both if you're going to fix it. So, some common principles here. So one, individualized treatment plan. I kind of hit that several times here. Functional issues trump cosmetic issues every time. So, problems with chronic wounds and skin irritation, problems with mobility, right? These are functional problems. May dictate the stepwise approach that you would pick to try and removing damaged skin. Where the skin that remains behind has also been damaged. So we're still dealing with damaged skin. And why does that matter? Tissue laxity. If the tissue too, right? They want to have a breast or a chest that ends at their pectoralis, major muscle, but they too have a breast fold that, if it's been stretched and lax, may be displaced down onto the abdomen. So it's an abnormal border. You can't use that border as how you define the chest for men. Rectus diastasis, so that's stretching of the tissue between the rectus muscles. I'll show you guys a picture of that. That's a tissue that's been stretched and damaged. If it has been damaged and it doesn't support the weight of the intra-abdominal pressure and the sutures are not holding, you could get recurrence of that stretching. So I'll explain all that in a second. Skeletal changes are not really correctable. And this leads to a lot of dissatisfaction with patients if they're not made aware of this ahead of time. So a few things that happen with having a larger build and body. So one of the things is your lungs have to work a little bit harder. Your diaphragm is pushing against more resistance. What will typically happen is patients tend to hyperinflate their lungs. And so over time, the rib cage has widened and the ribs have flared. And that's not something that I can correct by just adjusting soft tissue. And what does that lead to? Well, it leads to kind of a base frontal width that I just can't get any narrower, and that's true for the ribs. It also limits the flattening that sometimes I can get on a profile view, and that's really the one that women really want, is that side profile. They do. It's because it's so, you just look in the mirror and it's great. But those flared ribs I really can't do much about. Take a little bit of the fat under the skin on top of those, try and make it look narrower, maybe take in the low back, but again, it is a limitation and it's unavoidable. The loss of lower back hollowing for women, okay, we tend to have to hold that weight, our pelvis tilts, and so we lose that low back, hollowness or lordosis we call it. And that's a skeletal problem. I can try and mask it a little bit by thinning out some of this presacral fat, try and hollow that out a little bit, but again, I'm fairly limited there. And then the flared pelvis, right, especially at this upper part of the pelvic rim. This is probably more genetic based, but there are still some skeletal changes that occur with being a little bit heavier. And so that tends to give patients more of a what we call a V of the backside, so buttocks. It tends to narrow down to the waist, and then up at the top, the pelvic rim is pushed out. Most women would prefer to have kind of a more narrow that widens to the thighs and give an A-frame. And so it's very difficult to try and mask because, again, I can't fix the bone itself. Other problems are lymphedema, which I don't really talk about much, but that's usually at the lower extremities. It can also be of the pubic mound and arms, but those are the main areas. So what is a panniculectomy, right? So patient comes in, has had great success with their weight loss, and now they're ready to get their body back. They'd like to feel, maybe their goal is just to feel comfortable in normal types of clothes, and that's actually pretty common, is desire just to feel like you can shop, usually very high up on their mind. The short answer is it may cover your panniculectomy, and that's typically about it. A panniculectomy is not an abdominoplasty, it's not a tummy tuck. So these are pictures of, and I don't want to be discouraging, like I said, but realistic. Panniculectomy is of the abdomen is the hanging skin. Typically, it's of the lower part of the abdomen, although I've seen panniculi that are higher up on the abdomen. I've seen a patient who had 3 pannises. And so, so it's typically of the abdomen, usually hanging down, causes skin irritation. It's difficult for hygiene. And so the insurance company will pay to have that redundant skin, just that portion of redundant skin removed. If it includes the belly button in that redundant skin, then the belly button gets removed and not replaced, like in this patient here, no belly button. That came off with the pannus. This patient, panniculectomy does not include liposuction or fixing rectus diastasis, which can help narrow the waist. And so, this didn't necessarily improve the contour, but did improve the patient's function and mobility, okay? And so that's the purpose of a panniculectomy, and that's what it covers. It is fairly uniformly dissatisfying, I don't know, for most patients when they learn that it really is not going to get them what they're expecting to get, what they really want to get, which is improvement in the contour as well. But for some patients, they're satisfied with that. Typically does not go around to the back. A lot of writing here. It's actually not too bad. So I broke down kind of main insurers here, and Blue Cross, Cigna, Humana. United was very similar to, it was Cigna or Humana, I don't know, they're fairly similar anyway. Medicare, Medicaid's on here as well. This is for panniculectomy. Okay, this is what the insurers require before they'll cover the procedure. Okay, so we'll start with Medicare. So all of these actually have that the pannus, the abdominal pannus, hangs at or below the level of the pubic symphysis, so kind of the bony part right above genitalia there. And so some have at or below, and then others like Medicaid and Medicare, it needs to hang below. And they're pretty stringent on that. So you have to have column A, okay, and then you have to have column B. So for Medicare, documentation of recurrent skin breakdown, they don't really give much more specific than that. Some of these insurers require, here we go, treatment with topical antifungals, topical systemic corticosteroids, and or local systemic antibiotics. Some require that you've had 2 failed treatments with medical intervention. So you have to have column A, column B, and then some even have a column C, which are stipulations on how much weight you need to have lost, how long you need to have been stable at your final weight, and and Blue Cross Blue Shield now actually, they limit, you have to have your body mass index below 35 in order to qualify. So a lot of little hoops there, and I think they're put up intentionally as obstructions. Okay. Hello. But I do think that that's the purpose. So it's unfortunate, but there are options. They do differ, some of them. The mainstream ones, if you're Medicare, I mean, that's actually not too stringent. But if you have the option to change insurers, then you can do that if that matters to you. So most specifically state that they don't cover abdominoplasty, rectus plication, which is just bringing back together the rectus and abdominis muscles, or what they call lipectomy, which this is where they typically throw in arm and thigh lifts. Okay, so if it doesn't say arm lift or brachioplasty, sometimes it's tied into lipectomy, and so arm lift brachioplasty is specifically not covered by those insurers. So that's probably the worst part of this whole presentation, and this part is all the techniques that we'll use to try and improve the body and the contour after significant weight loss. I break it down by kind of areas of focus and things that you may need to appreciate and fix depending on the patient's body type. So for the abdomen, there are different skin excision patterns. A traditional tummy tuck we'll show you pictures of, a fleur-de-lis, which has the lower incision and a vertical incision, a circumferential or belt lipectomy, a reverse abdominoplasty, where instead of pulling the skin down, you actually pull the skin up. It's less common, but occasionally you would consider that. Rarely you would consider that. A rectus plication, I know we're going to get there, but it acts like an internal kind of girdle or corset. Liposuction, again, if we need to improve contouring. Monsplasty, okay, that's just fixing your mons pubis. And then the umbilicus that has either moved or been damaged, you can reset it and reposition it and make it look better. The back, so you have to address the buttocks as well as the back itself. You can do a buttock lift or remove excess skin of the low back. You can, just like a reverse abdominoplasty, you can kick the skin up in the upper back. I'll show you guys that. Liposuction again, gluteal augmentation. So if we can't create much of a hollow here by hollowing this down, then if you take the buttocks out, then that can also create that lower back groove or contour, and you can do that by using your own tissue, gluteal implants, which I don't do, or fat grafting, which is becoming much more popular, and then breasts, a variety of different procedures for the breasts. Lifting removes damaged skin and puts the breast tissue back up on the chest wall. You may need a breast reduction. Maybe you have too much breast tissue even despite significant weight loss. And then volume replacement. If we've lost significant volume in the breast, how are we going to get it back on there? Is it going to be with an implant, which you need to have support for because it weighs significant weight, or you're going to provide the volume with fat? So an abdominoplasty, okay, what is typically involved with a tummy tuck, okay? Removing excess damaged skin, all right? Fixing rectus diastasis or abdominal wall laxity, and that's why this kind of looks bulged between the lateral sides of her rectus muscles here. I'll show you that later. Repositioning and restyling her umbilicus, okay? Improving her waistline, which is the part below the ribs and the top of the bony pelvis. By narrowing that, you have a couple ways to narrow that. And then liposuction. I just show this as typical markings here. So these are the areas that we're going to liposuction in red. Obviously I did a breast procedure for her as well. The tummy tuck, so I did not quite remove all of this skin, but probably from this point to that point is this, okay? And this is some liposuction that we did in these areas, and maybe a little bit on the waist. And that's not tremendous amount, but just enough to get a little more contour in the waist. And here she is, only 2 months out. Okay. We did the breast procedure too, but just to show you, these scars do tend to fade. They're a little bit dark right now, and hidden by most styles of clothing. You see how the rectus bication, bringing those rectus muscles back together, it helps tighten that silhouette in the mirror. Okay, right here. All right. Ideal candidates. So ideal candidates, this one's really big. So no nicotine exposure. That's, you know, gums, patches, vaporizers, second hand, third hand, whatever hand. We really need to avoid nicotine. So nicotine causes spasm of blood vessels, and by narrowing the blood flow, particularly to the skin, we're going to have less delivery of oxygen and micronutrients that you need to heal wounds, as well as less oxygen delivery and white blood cells to help fight infections. So inevitably, these lead to can lead to outright skin necrosis, where the skin just dies. It can lead to wounds and infections. It also leads to fluid collections called seromas. And so absolutely required by my practice is no nicotine. Okay, we need to get off it. And it's not fun to have to do dressing changes for several months. It's not fun. And you know, me as the surgeon, I don't do those dressing changes. The patient has to do this for several months. And so it's not fair to them. Stable weight, this is, you know, the insurers, whatever, you know, 3 to 6 months is pretty reasonable. Right? BMI less than 35, I do agree with Blue Cross Blue Shield about that as far as limiting risk for complications. And ideally it's less than 30. And the rationale there is for every increase in 5 of the body mass index, we find that for elective and cosmetic breast surgery, there's a doubling of the risk of wound healing problems and infections. Okay, so 2025 have a rate for wound healing and infections. Next 5 is double, next 5 is double, next 5 is double, etc. So even at 30 to 35, we have some real risks that we have to take into account. Doesn't mean it's a no-go. Okay, it just means the patient has to have eyes wide open as far as complications. And they can help minimize that if they're below 30. Minimal visceral fat for tummy tucks, okay? And I'll show you why that's true as far as contouring. And then medically safe for general anesthesia. And then you can add up your, I guess, skin perfusion. So you can't really see it here.
Oops.
Oh, all right. Sorry, that's okay.
Start over.
Yeah, exactly. Oh no, I'll leave. So this patient, you can't really see it. She's got a scar from here to here, big saber slash. She had a big, or you can kind of see it here and maybe a little bit here. She had a big liver surgery in the past. She also was kind of a brittle diabetic, not from her own choice. She just was very hard to control her diabetes. Very compliant patient, but because of this big scar she had here, I couldn't do the normal incisions that I would make for a tummy tuck, because this skin right here probably wouldn't have made it, okay, and that skin would have died. And so I told her, you know what, I'll still get rid of these hanging pockets. You know, she really did not like her front butt crack, as she called it, but I couldn't make that better. I did a little bit of liposuction here, just to try and thin it down a little bit, and then just took off the hanging pockets. She was very, very happy with this result. Okay, but it just shows you that, you know, some patients, even though she fulfilled kind of all these criteria, still was not a great tummy tuck candidate. Now, we mentioned this visceral fat. So, these are 2 different patients. The first patient here came in for a consultation with me. The second one came in for a consultation after someone else had done a tummy tuck and liposuction for her. So, this patient was really bothered by this hanging skin here. Okay, it's not very massive in my opinion, this was what was bothering her. This was what was bothering her. This was what was bothering her. But in the mirror, this is what was bothering her. Okay, and so if I were to do a tummy tuck for her and take off this skin here, what it'll end up doing is pull in this lower part of her abdomen, and she'll still have this kind of bulge and fullness at the top. Okay, and it'll look kind of like this. Okay, so this patient had that lipo and tummy tuck done elsewhere. She came in to me, so this skirt looks like it's pulled tight, pulling everything in, but it's not. This is, you know, fairly loose. This, without her skirt on, she looks the exact same as far as that kind of tucked in pelvis and paunchy upper belly. And she came in saying she felt like she was a linebacker and hated it. And what could I do for her belly? And I told her I can't do anything. That's all fat that's on the inside of the abdominal wall. What I could do for her was reduce the size of her breasts and make her a little bit less top heavy. And so that's what I did for her. So, you know, this is not a great tummy tuck candidate because you might create something that looks worse. So for post-bariatric surgery, for my practice, I do recommend at least 1 year after your procedure, okay? And it's kind of funny, it's the inverse of the severity of your bariatric procedure. So if you had a very aggressive bariatric procedure like a Roux-en-Y, it's less time after the procedure before you can contemplate doing your body contouring because you lose that weight fairly significantly and you can stabilize sooner. Sleeve or partial gastrectomy is kind of a year and a half, and then lap band, I use 2 years. I have, you know, suspicions about that because a lot of patients will tend to gain the weight back pretty quickly. And so I don't like to do all of these surgeries with all of the complications, cost, and recovery. If, you know, in 2-3 years it's not going to look like we did anything. It was not fair to the patient. They're out significant time and money. At least 3 to 6 months stable weight, like I said before. Ensure no hernias. And I saw a patient recently who probably had it was a massive hernia. It was so big she thought it was just rectus diastasis, but it was a big hernia. And so I sent her to get that fixed first. Diabetes well controlled, usually not a problem actually. Usually if they've had significant weight loss, the diabetes has been either fixed entirely or is at least very well controlled. So this usually isn't a problem. I recommend a hemoglobin A1C of 6.5 or less. And some people will use 7 as their cutoff. But even at 7, you're fluctuating with some periods where your blood glucose level is too high. Even at 6 to 6.5 is a little bit elevated. And then appropriate expectations. If you don't have appropriate expectations, then it is really not worth the effort. Okay, so this patient, she did not want a vertical incision. So we're really only addressing the top-down skin excess, okay? She actually did not have bariatric surgery. She lost her weight with diet and exercise. She started teaching yoga. And what prompted her to actually come to my office was she said she hated being in a plank and feeling like one of those multiple pregnancy cats. Belly on the ground. It was really, it was like, oh God, okay, let's do something quick. And so here, I don't like to do a belt lipectomy. That's the circumferential all the way around where you're addressing next to the skin in the back as well as the front, because you're limiting how much skin you can take from the front side. Okay, I want to take as much skin as I can from the front because you'll have swelling. The skin will stretch. Some of the laxity will rear its head again, and ultimately, when you're walking back upright, everything's gone down. It's still relatively flat. If you just cut off enough so that the patient's upright, When all those things happen, the swelling goes down, the skin laxity comes back. Now they're going to have a little bit of redundancy that hangs over the scar, and that drives them crazy. And if you're going to try and remove skin from the front and the back, the best position to be in then is straight. So they compromise the front, okay? The problem with that, from my perspective, is the patient only sees themselves from the front. And so they come in saying, hey, my skin's hanging over my scar, you did it. So I do break those up, the front and the back. The other reason to break up the front and the back is if you need to do dressing changes, and it's not uncommon to have a small wound and these big incisions, right? An incision that goes all the way, almost around her body. Here, I'll show you. Patients and on both sides, all the way around, okay? This, for reference, is a little over 6 inches, okay? So that's how much skin we took out. Pretty cool, huh? Above her thumbs here. Yeah, and so she liked her tummy tuck. She came back later and we did some breast implants. So now, it didn't do a whole lot for her waist because we didn't do any liposuction. She didn't want it. I didn't do the vertical incision that I'll show you in a minute. So she still had a little bit of laxity side to side. Doing a side plank, she wouldn't notice that. So this patient, she wanted as much skin gone as possible on her belly. We also talked about her thighs. We talked about her mons, and you can kind of see the mons here, right? Fairly droopy. I do address the top-down skin excess at the time of a tummy tuck, but I don't really address the side-to-side excess at that time. Okay, it's just more incisions, compromising blood flow. So I don't. I pretty much took all of this off, this marking, from here down and here and up. And that was this. So pretty good. This is what that looks like on the table. So this is called a fleur-de-lis abdominoplasty, and that has the vertical component and the side-to-side component. You could offset the belly button to one side. You can I just put it right in the middle where it was. They do have a tendency to widen the belly buttons, make it more of a big circle, you'll see in a little bit. I do use drains. When I do a fleur-de-lis, I don't combine it with liposuction just because I'm concerned about wound healing. It's very common to get wound right here at this T-point, okay? And she may have had some, I can't remember. And here you go. So, pretty dramatic difference. We probably did rectus plication, I imagine we did, because you can see the edge of her rectus mostly here and here. No liposuction, so the back, maybe slight improvement as the skin kind of rotates up and around. Not tremendous impact on her medial thighs. Probably a little bit of improvement in her lateral thighs because that's also pulling up. Okay. Super happy. This patient's in her 30s and she had her wedding coming up. And so I also think she wanted to get ready for her wedding. But anyway, so she wanted as much skin off as possible, and so we did the fleur-de-lis. And so these are the markings, this is the vertical component, and this is what it looked like when we took it all off. Okay. Looks like a nose, but it's not a nose. And this is her on the table, so how marking a patient upright and then putting them in a lying down position changes things dramatically, right? So this shows you just how much of her abdomen had to then get stretched down to whoop, there. There you go, off the end of the procedure, flat. No liposuction. And so here's that widening that can happen. So I had one patient tell me it was her cat butt, okay, on her stomach, which is very flattering for your plastic surgeon to say they give you a cat butt. But yeah, so tremendously happy, buying the normal shirts that she wanted to for her age. Rectus plication. So here you go. So let's orient you here. So the person's groin is here. The legs are kind of coming at us out of the screen. Her head's going into the screen, and this is that lower incision that I would make on the tummy tuck. And here's the inner edge of her rectus muscle, and this is the inner edge of her other rectus muscle. That goes all the way up to the xiphoid process, the bottom of her sternum. This thing right here is her belly button, right there. Okay, it's right there. So you can see how this bulges out the rectus muscles, right? There's some widening between here. And so when she bends forward, I just use a skinny patient so you guys see what that looks like, right? So I know it's not, she didn't have massive weight loss or significant weight loss or whatever. She's a multi-marathon runner. But you can see how fixing that rectus muscle can help flatten this profile, pretty significantly. Okay, no liposuction. This is fairly straight line, and now we got a little bit of a curve in here. This is what I removed. I removed her tattoo. There you go. More rectus diastasis. So this patient came to me, and she's had 5 pregnancies. I thought she was on her 6th pregnancy. And I was like, are you sure? And then the mons also is a little full. I include this one just so you see that you can still get some recurrence, some laxity, some bulginess here, okay? Because when it's stretched out like this, that tissue is so damaged, it doesn't really hold suture well either. And so it will start stretching again, okay? So that can happen for anybody. And I'll show you that later. This is just more plication, and this one had some liposuction. Again, not a significant weight loss, just showing you the improvement. This patient, we did some liposuction first. She had fairly stretchy skin, actually. A lot of deflation on her backside, too. And so we did liposuction, not here, just of the areas that were going to remain on her front or back. I avoided this area because I knew at her tummy tuck we would cut that off. And so you get even more dramatic result, right? And she's got that nice line in the midline. And she's 50 years old. Significant weight loss, dramatic stretching. I include this picture because, it shows, what we're able to do and what we're able not to do. Not able to do, how about that? I told her ahead of time, I can't get this stretched skin out, and in fact, sometimes it looks worse. Because here it's not under tension and it's kind of finer lines. When you pull it down and it's under tension, it kind of splays them apart. It may make them more noticeable. She didn't care, but probably because I told her about it ahead of time. She has a little bit of recurrence of kind of this paunchiness right above her belly button, but pretty mild. Here's an upper back lift. So this patient had significant weight loss, is hitting the gym. This is a female patient. She had this extra skin that just wouldn't go away, all right? It's not tremendous, but with her in the gym, it was bothering her. Her bras would push it down and create folds. Very common that happens. And so what we did was an upper back lift. It's just like think of it as a reverse tummy tuck for the back, where you just take the skin up. I have a great picture of that, actually, the markings. But essentially mark the top of her bra, and then kind of the apex of these around on the sides, and back up to the breast. And then, so I took out probably from here to here, less on this side, more on this side. And there you go. This scar does widen. There's a lot of tension to pull that scar apart because there's the weight of the mid-back, which I did not do any liposuction here. I just did liposuction in her lower back, give her a little more hollowness. But yeah, it'll hide under her bras, not an issue. So let's talk about some breast surgery. So we kind of did a little bit of the belly, a little bit of the back. Another common area for patients for me is breast surgery. think of the breast as what we're doing for the skin component and then what we're doing for the inside components, okay? Getting the breast tissue back up on the mound and then recontouring the skin, getting rid of the excess stuff. And that'll also help reposition the nipple, okay? So for this is an inverted T skin pattern, okay? So this is talking about the skin that we're going to excise. So in this drawing, it would be all the skin in between these black lines. All that skin gets kind of removed, and then this is kind of what we're doing on the inside, but all I just want to show you is that's these lines here, right? Is right here, and the circles where the nipple is in, areola is in, okay? So this is maximum skin removal, okay? That's what that helps us do, okay? By giving us a scar that will ultimately go around the areola, a vertical scar, and then a scar across the bottom fold of the breast. And that looks like this. So here are the markings that I would do before surgery. I come in later and measure out where the new nipple and areola will be. And so there you go. So that's the markings, and this is what the final result looked like on the table. A scar across the bottom, a vertical scar, and a scar around the areola. You can also have a vertical skin incision pattern, which essentially is just a vertical line and a scar around the areola. And you just don't do this side-to-side component here. You just leave skin redundancy. I'm not a big fan, to be honest, because without having that horizontal fold component, it puckers right here. You have excess. And it has a fairly high revision rate. You need to go back and do more surgery and cut that out. And you're going to add the scar later anyway. But meanwhile, in the many months leading up to that, you're worried about it. And you're like, oh my God, is this going to go away? Oh my gosh. It's just not worth it. So I don't do that, but plenty of people do. So now what are we doing on the inside? So that's this kind of diagram, right? So inferior pedicle. Inferior just means from below, and pedicle is where our blood supply is coming out to the nipple, okay? Every tissue needs blood supply to survive. So leaving the nipple attached to breast tissue from below is an inferior pedicle, okay? Now the problem with this is that then most of the breast tissue that remains is still based lower on the breast. That's where it wants to be, that's where gravity's gonna pull it back down. And so drawbacks are it tends to give you over time this boxy shape, okay, to the breast, kind of a squared off shape. And that's one of my patients, so I can't blame someone else. But yeah, here are some other examples that are better, maybe. Also my patients, so inferior pedicle. There you go, inferior pedicle. She's 64. And you can see, I love some of the very, very droopy breasts because you could see in relationship to scars as landmarks just how much lift she got. This was still a reduction. I still reduced the volume of these breasts and tried to contour it where her elbow is, elbow down here. So she's had some chronic skin discoloration. You can see that. That's not just shadow. That's just from her breast lying there for years. Here's a more exciting one. It's an 18-year-old though, so it's not really a significant weight loss, but this just shows you that even very large breasts, you can get the nipple to survive. So this is an inferior pedicle. This is not a free nipple graft. Her nipple stayed intact, so she has sensation. Theoretically, she could still breastfeed, and at some point, maybe she'll try, I don't know. So those were inferior pedicles, leaving the breast tissue from the bottom. Now we have one where we leave the breast tissue attached from the top. And this is becoming more popular, and especially with me, I like it too. Because by keeping the breast tissue up top where you want it, it doesn't droop as much. It tends to leave a better long-term result in my patients and more roundness. So here's an example. Okay, fairly heavy breasts. More roundness, which will maintain that better. younger patient, significant areolar stretching and nipples that are out to the sides. Here you go. So, she has a waist now. And she should maintain that roundness. Here's the marking for that, just showing that this is some of her native areola that I couldn't get out, and that winds up